Hello, this is Sam Kingsley, and welcome to my case review on migraines. So we'll start off with a case here. This is migraine. He's a 44-year-old man with hypertension and migraines. The headaches prevent him from working. He has trialed beta blockers, but they were ineffective. Right now, his prescriptions are diltiazem CD 120 mg and Imitrex 50 mg PRN for migraine. So it's important to know that migraines are a clinical diagnosis, so therefore your patient interview is going to be the most important thing that you could probably do. It's essentially going to be a pain assessment because migraines are a type of chronic pain. And so you're going to look at your pain assessment, duration, quality, frequency, location, whether or not there's an aura, medications tried, anything that works, anything that makes it worse, and effect on quality of life. There are a lot of different migraine tools available. You're probably going to want to go out there and look and find one that's going to be good for you. I went to eMedicine and they had a migraine tool posted right there that goes through everything that you're going to need to know to make an assessment for migraine and then characterize and later diagnose. Also important to note that identifying patient goals are going to be very important. Some people live with chronic migraines and they just want to see some kind of little reduction and then they'll be the best that they could possibly be. Other people get one migraine once a month, once every 2 months, and it's the worst thing ever. So it's important to assess where the patient is at in terms of where they want to get with their therapeutic goals. So we do our assessment on Mr. Grain. Mr. Grain reports that his headaches last 8 to 12 hours with a throbbing sensation unilaterally around the ophthalmic region. It can be either his right or left eye, but is only one every time. They occur 1 to 2 times weekly, so that's 4 to 8 times monthly, and it causes him to miss work, and he works as a teacher. Bright lights and movement of his head make it worse. Dark rooms will make it better. Reports seeing a zigzag feature that originates near the point of fixation and radiates right. I've tried beta blockers and diltiazem for prophylaxis and Imitrex for abortive therapy. I haven't seen any improvement in frequency, and the Imitrex only works about 50% of the time. Mr. Grain has a history of primary hypertension that has been controlled while he's been on the diltiazem, and states his goals are, I would like to be able to not have to miss work as much because of my headaches. So the American and International Headache Society are the ones who classify types of headaches. They have publicly available diagnostic criteria for headaches. I went right to the International Headache Society. You can download the entire list of classification for headaches. And looking at those criteria and based on what Mr. Grain is displaying symptoms of, it looks like he has a migraine with aura. You can go in there and it has a lot of different stuff on sort of genetic ideas, and causes of migraines. There's no known pathophysiological cause of migraine at the moment. It's somewhere between a vascular and a neurological condition. So you can read more about that, and I would encourage people that if they're working a lot with headaches, there's a ton of different types of headaches, and just to kind of familiarize yourself with the different classifications is going to be important. Obviously, headaches can mean really bad things in certain people, and other times you're looking at more of a classical migraine. So it's important to be able to differentiate between concerning headaches and more of your classical signs and symptoms. So when we're looking at more of a differentiation, the International Headache Society recommends against imaging for migraine or tension type headaches. So these classical symptoms that Mr. Grain is displaying here, you wouldn't necessarily go to an MRI or a referral to a neurology or headache specialist. There's something like 36 million people living in the United States that have some form of chronic headache or headache disorder. And neurology, there are less than 1,000 headache specialists out there. So this is very much going to be a primary care undertaking. So it's good to then to familiarize yourself with migraines and tension type headaches. And also, as I said before, the differentiation between concerning headaches and typical headaches. So There are a bunch of different types of headaches. You have ones that involve intracranial pressure. There are psychiatric. There are drug-induced, caused by infection, vascular disorders, trauma. There are lots of different types. There's also some genetic components. There are familial migraine disorders where the gene has been identified, and you can do testing for that. So again, good to get out there and familiarize yourself with the different types. All right, so looking at our treatment approach, we have a few options. We have our, of course, pharmacological, and that is broken down into prevention and acute treatment or abortive therapies. There's also over-the-counter, and we have non-pharmacological, things like lifestyle changes and acupuncture. And again, always be considering patient goals when we're looking at what our treatment approach is going to be. And in terms of efficacy, there are ones that seem to be better than others, but there's no one drug that really kind of stands out above the rest. So it's very much a choice among a bunch of different type of drugs that we're going to be looking at, and we'll see that on the next slide. So our prophylactic drugs for migraine, we have our anti-epileptics. We have topiramate, Depakote, and gabapentin. We have our antidepressants, and those are going to be amitriptyline and venlafaxine. We have our antihypertensives. Those are our beta blockers, especially propranolol and metoprolol. Our calcium channel blockers, like verapamil and ditiazem, and candesartan is ARB, and that's also going to be an option for antihypertensives. Botox is an interesting one because it's marketed as a treatment for migraine. However, the evidence shows that it's actually no better than placebo. It's a very, very expensive placebo or acupuncture, basically, because you get about 20 injections into your face. And then also some of the newer drugs out there, the monoclonal antibody therapy, those are extremely expensive and extremely new, so probably not going to be a great choice for a lot of people. So then looking at our drugs for acute or abortive therapy for migraine, we have our triptans. So we got sumatriptan, naratriptan, rizatriptan, zolmitriptan, and our ergot derivatives, dihydroergotamine. Those are all serotonergic type drugs. We have our NSAIDs, over-the-counter, naproxen or ibuprofen. We also have Tylenol. Caffeine has historically been a treatment for migraine, and the data seems to point that those who are caffeine naive would have more of a benefit than someone who drinks coffee every day. But caffeine is an option out there for people. And then we have our dopamine agonists, our bromopride, metoclopramide, doperidone. So we know what all our drugs are, and so let's go back to Mr. Grain, and we want to improve frequency in abortive therapies so that Mr. Grain doesn't miss so much work. That's his goal. So for prophylaxis, we still want to try and focus on co-treating the hypertension. So we can either switch to another calcium channel blocker, or we can go to candesartan. Candesartan actually, from what I found, has the best evidence for your use. It has a strong recommendation, and with moderate evidence according to the Canadian guidelines. So I'm going to go with that, and we're going to start him off on 16 milligrams of oral daily. And then looking at his abortive therapy, so we can either increase his sumatriptan, Imitrex, to 100 milligrams, or we could switch him to sub-Q. The evidence that I looked at says that switching to sub-Q would actually be the most efficacious thing that we could probably do. My recommendation is that as long as he's okay with doing an injection, then that's going to probably be the best thing. If he's not cool about doing injections, then we're going to bump him up to the 100 milligrams of Imitrex and see go with that. But let's just say that Mr. Grain is cool with doing a sub-Q. So that's what we're going to do. So we're going to take a closer look at sumatriptan or Imitrex because it's probably a drug that most people aren't super familiar with unless you've done a lot of work with migraines. It's not a drug that I think has a lot of uses outside of migraine abortive therapy. So when considering sumatriptan, we want to look at, of course, our drug interactions. It's serotonergic, so there is a theoretical risk of serotonin syndrome. So we want to avoid giving this with other triptans or ergotamines, and also be aware of other serotonergic type drugs, especially our antidepressants. Three side effects that you're probably going to want to know with this: arrhythmia, hypertension, and overuse reaction. Um, there is a caution for use of this in patients with hypertension. It doesn't seem to be a big deal if you keep it under 10 times per month usage. So that's usually going to be your recommendation. Actually, usually it looks like people recommend 8 or less per month just to be on the safe side. Of course, you want to be aware of any existing cardiac complications. Mr. Grain, he has hypertension. We don't know anything beyond that, but based on what we're doing here, he just has primary hypertension. So we just want to be aware of any further cardiac complications. Overuse reaction: if you do use it more than 10 times a month, you're going to the chances of cardiac complications or like a hypertensive crisis do increase. So things you want to be telling the patient: you want to try and keep this to 2 times per week or less, 8 or less for the month, and you can suggest to switch to like a Aleve or Tylenol kind of abortive therapy if they're having more than 2 per week, or if they do 3 a week, maybe the next week you only do 1. It's not a hard guideline, but it's something that you just want the patient to be aware of. We want to keep it 8 or less a month just to be on the safe side in terms of the overuse reaction. You can use it twice if your headache comes back, and so after 2 hours you can go again and use it. That is okay, but again, looking at the overall usage for the month is important. Also, we want to avoid the use of herbals, especially St. John's wort. That's going to be serotonergic, and as I noted already, we have a concern about serotonin syndrome. And also, you want to teach the patient what to look for in terms of injection site reactions. There is some anaphylactic type reactions or allergic type reactions to this medication. So that's our last slide. I hope you all learned a lot in terms of treatment for migraines, and thank you very much.